This is advertising material.
Good morning, everyone. Thanks for joining us today. We're going to talk about the hard truth treating the rural opioid epidemic. I am Lisa Hinkle. I'm an attorney with McBrayer, McGinnis, Leslie, and Kirkland. And to my right is Gina Riddell, who I simply cannot say enough about. She has her master's in public health. She is a certified compliance officer, and she has been my right-hand person for 15 years. And I will say that Gina and I both personally are concerned about this opioid epidemic.
Absolutely.
You know, when you really stop and think about the numbers, it's just truly tragic. If we could go to our first slide. Opioid-related overdoses, which are generally attributed to either heroin or fentanyl, are continuing to rise across the country. Now, in 2015, more than 33,000 people died from opioid-related overdoses. But let me tell you a little bit more about what some of the more recent statistics show. In 2016, it was a shocking 65,000, more than 65,000 individuals died from drug overdoses. Of that 65,000 people, more than 42,000 people died from opioid overdoses. Now, what that means in terms of every day, it means that 142 Americans die every day from opioid overdoses.
And, you know, another thing that is so horrible is just in Kentucky. Kentucky's numbers are exceptionally high. We have, for the last 5 years, remained in the top 5 states for opioid deaths, and those are continuing to climb because of the fentanyl issue.
Well, and the other thing that's so surprising to me is that drug overdose, opioid overdose, is the number one killer of people under 50. That's just tragic. Let's hit the slide. Interesting, roughly 80% of people who use heroin or fentanyl have first misused prescription opioids. Now, one of the things that's also near and dear to our hearts, because we do so much work and have so many clients in Eastern Kentucky and Appalachia, is that when you really look at the statistics for the Appalachian Mountain region, it accounts for 22% of the nation's opioid-related deaths, despite representing only 20% of the population. Essentially, what that means is that Appalachia has even higher rates of overdose deaths than any place else in the country when you look at the counties.
Absolutely, absolutely. And, you know, the CDC is pulling more data together right now. They're looking at this. You know, they have truly declared this an opioid epidemic, and the Appalachian mountain areas are absolutely just, the numbers are so high and continue to rise.
Another thing that is related as well to this is that opioid-related inpatient stays and emergency department visits rose 65% from 2010 to 2015. 40 million people also in Medicare Part D received prescription opioids, and this has precipitated a review of the use of opioids, and within the Appalachian population, the use of opioids is much higher than in other parts of the country.
Absolutely. And, you know, there's many reasons for that, Lisa. One, you know, with our culture in the Appalachian Mountains, we have a lot of coal miners, people with jobs that have intense labor, which causes some of these chronic pain issues, and which we'll talk about in a little bit.
So, rural providers are on the front lines of the opioid epidemic, Truly, it is the rural providers, and particularly rural health clinics and primary care providers, who address, treat, and deal with people who have drug issues. And with regard to that, let's talk a little bit about what the fallout of all this is. The opioid-dependent and addicted patients of the Appalachia have additional risk from general opioid use. Of course, there's risk of overdose. There's the neonatal abstinence syndrome, babies born in problem.
And that's another area, Lisa, that we have seen a significant increase is with our pediatric patients being exposed to opioids and having issues as well. So that's another area of concern for our rural health patients.
And of course, hepatitis is a huge concern. HIV, I mean, we've seen clusters of high rates of HIV.
Yes, and because, you know, a lot of the intravenous drug use is the cause of that hepatitis C and HIV, which is, we've not seen those numbers rise until recently. And now, because of the opioid epidemic, they seem to be going up.
And as I think all of our primary care providers and anyone who has treated anyone who is opioid dependent, essentially being opioid dependent creates other problems to your entire body, gastrointestinal, musculoskeletal, etc. So the opioid dependent patient is probably at much higher risk than others for adverse health consequences. Here's some information about, we call it NAS. You know, it was striking to me the number of pregnant women in eastern Tennessee who abuse opioids is more than twice the national average. Appalachia. One baby suffering from opioid withdrawal is born every 25 minutes.
Yes, it is.
The next slide is some information about hepatitis C and HIV. I think it's incredibly interesting that the Appalachian area reported a larger number of new HIV cases compared to most other areas in the nation, and then hepatitis C rates tripled since 2010.
It's been an extreme increase because of the intravenous drug use.
And, of course, dealing with all these adverse general health consequences, the cost is huge. In fact, CDC estimates that the economic burden of prescription opioid misuse is about almost $80 billion a year. Now, that includes lost productivity, addiction, treatment, criminal justice, and et cetera. That is a problem. Mm-hmm. But in Appalachia, it is our rural healthcare providers who are generally the most accessible facilities to patients who suffer these problems.
Yes.
And it is our rural healthcare providers that shoulder the burden of addressing these.
Absolutely. And in many of these counties, there's not a local hospital or any instant care that these patients can go to, so they do go to the rural health clinics for their opioid issues.
Now, today we're going to talk to you about 3 ways rural health clinics and rural health care providers can fight the opioid epidemic. We're going to suggest to you first that you add behavioral health services to your complement of services. We're going to talk to you about learning and training and using best prescribing practices. And then we're going to suggest to you that it is so important to have a compliance program, but also one that is comprehensive and that includes tools that are designated to address some of the opioid issues. So we hope we'll be able to give some good information to you. If you have any questions, we would love to take questions. I think we've got it set up so you can email questions, and hopefully we'll have some time at the end to talk about those. So, okay. First thing we're going to talk to is about adding behavioral health services to your rural health clinics. Now, of course, please understand that Kentucky does cover substance use disorder treatment, although we've had a mixed bag in how we've done that. We're going to address this a little bit later in more detail. But there are certainly regulatory requirements for prescribing Suboxone, both for nurse practitioners and for physicians. And essentially, there's also House Bill 33 designed to cover fentanyl abuse. So we'll talk about those a little bit later. But I want to switch over to talk about behavioral health. And let me tell you why I think that behavioral health, and we use that to include both mental health services as well as substance services. But let's talk about behavioral health just for a minute. Let me give you some information about why we think that adding behavioral health services is so important. More stats. According to the CDC, suicide deaths are at currently a 30-year high. In half of states, the suicide rate has gone up 30% since 1999. Suicide is the 10th leading cause of death in the United States, and it is the second leading cause of death among Americans ages 10 to 34. Now, for children, according to the National Institute of Mental Health, 50% of lifetime mental illnesses begin by age 14 and 75% by age 24. 20% of youth ages 13 to 18 live with a mental health condition. 50% of students age 14 and older with a mental health issue drop out of high school. The average delay of symptoms between onset of symptoms and intervention is usually 8 to 10 years. Now, to talk about seniors, I have some of those near and dear to my heart. In the next 20 years, the number of seniors with mental health conditions is going to double from 8 million to 15 million. Seniors are 13% of the population, but account for 16% of suicides. Less than 3% of older Americans report seeing a mental health professional ever. There is one elderly suicide every 80 minutes. Without question, our primary care providers, our rural health clinic, our rural providers are seeing patients with mental health, behavioral health issues.
And, Lisa, in our area, and actually it's nationwide, there's such a shortage of mental health providers. And so rural health clinics do see a lot of their patients for those behavioral health issues, and it's so necessary. And in tying that in, how does providing behavioral health help curb that opioid epidemic? So many people try to self-treat themselves with illegal medications. And so it's just a catch-22 in those systems. And so, the rural health clinics are just a great way of being able to help prevent some of those issues by working with those patients and those adolescent patients to get them that behavioral health that they need.
Yeah, I also think it is very important. I'm sorry this slide has been up so long, but mental health disorders include covered services. In fact, for rural health clinics, screenings and assessments, psychological testing, and crisis intervention is all covered. Medicare's benefit policy manual covers what is defined as a mental health visit or a qualified preventive health visit. The visit must be a face-to-face encounter between the patient, a physician, a nurse practitioner, a PA, nurse midwife, psychologist, or social worker, during which time one or more rural health or federally qualified healthcare services are rendered. So they're covered services. In addition to medical problems, a patient may have behavioral health issues, as you addressed, that can be identified, and a comprehensive care plan can be coordinated using a team approach. Typically, however, our primary care providers are covered up with dealing with traditional primary care problems and are not as well versed in diagnosis and treatment of behavioral problems. Thus, we think adding behavioral health providers to your rural health clinic provides an improved level of expertise. Again, the medical and behavioral health providers may be reimbursed for services, this is interesting, performed on the same day at the same location in a rural health clinic. So what that means essentially is that you could have a visit for a traditionally medical problem that is covered as well as a visit for a behavioral health problem. So the other thing, and this last bullet point kind of gets to this, we want to suggest to you that incorporating behavioral health within a primary care practice, within a rural health practice, essentially has the ability to remove the stigma of visiting a practice that is specific to behavioral health. In other words, reaching out to your traditional healthcare provider takes away stigma that you might otherwise experience if you were going someplace else.
And one great thing about integrating behavioral health to me is that I believe that a lot of persons that suffer from opioid use disorders are literally afraid to go to the doctor for being turned away, and providing those services to where they can receive both their primary care and their behavioral health care is just a wonderful thing to happen.
Now, we talked a little bit earlier about integrating behavioral health. Here is a list of the types of behavioral health providers who are eligible to provide reimbursable services in a rural health clinic under Medicare's policy manual. Psychologists, social workers, nurse practitioners with proper behavioral health training. And I do represent clients. I'm so proud of those clients, nurse practitioners who've gone on and gotten their psychiatric certifications, certified nurse midwives, physician's assistants, and those with physicians with proper behavioral health training. Now, understand too, there may be some other types of professionals that do have some kinds of licenses that are not recognized as being able to provide reimbursable services in a rural health clinic. And some of those might be your alcohol counselors and some folks like that. So it's really important that if it's going to be reimbursed, it has to be provided by one of these types of practitioners. Let's see. As we talked earlier, it has to be a face-to-face encounter. We can address telehealth a little bit later or in another session because there may be some ways you can do telehealth that in a rural health clinic and provide behavioral health services, which would be so important. Now, this is another thing. A lot of times when we talk about mental health services, we talk about group therapy sessions and particularly with substance disorders and et cetera. But please note, if you're going to provide therapy in a rural health clinic or a federally qualified healthcare center, it has to be an individual face-to-face encounter, and it doesn't mean group therapy is not reimbursable as a rural health clinic service. Okay? All right. Let's see. Behavioral, they generally fall into two categories. First, those are patients who have specific behavioral health diagnosis. They've been diagnosed with a psychiatric problem. And I think patient, family, and group psychotherapy, it should be just patient, family. There is some psychotherapy. Medication management, crisis, psychotherapy, psychoanalysis, and transitional management services. And these would be billed under the appropriate CPT codes, and the code will depend upon service provided as well as credentials. Okay, the second one is essentially patients who present, and what you would do is health and behavioral assessment services. So a patient comes to you but does have depression or chronic health issues, diabetes, obesity, or hypertension. And those behavioral health services help patients address those kinds of compliance issues, compliance with treatment, and et cetera. So that's a little bit of a different take on a behavioral health service. It's not addressing a specific psychiatric problem, but it is essentially helping someone deal with their behavior and improve their function.
Yes, absolutely.
So that's a good thing. So you want to integrate behavioral health services. Where you begin, you need to really think through what your goals are and prioritize them. We think it's best to start small first, but be very sure that you have integrated, that you have the right kinds of providers, that you have the right kinds of tools, policies, and procedures, and start small and build up.
Yes.
Okay. We also think it's really important that you understand reimbursement. Reimbursement drives healthcare. Of course it does, but it's important to understand the codes. We talked about providers, focus on the services that are reimbursable, and understand the different treatment models.
Yes, absolutely. And this actually also to include your coding for laboratory services. If you have in-house laboratories, sometimes those can be a little hairy, but we can work through that.
So understand what the coding is, et cetera. Now, if I have to hire all these people and I'm going to have to add policies and procedures and do all this work to include behavioral health, what am I going to do about my rate?
Exactly.
Well, this is what I want to suggest to you, that understand that for rural health clinics, that there is something called a change in scope, which when you add services and et cetera, you can essentially request a change in scope, and essentially, if you could qualify, you can have your rate increased. So this is what we want to suggest to you, that when you plan to integrate your behavioral health services, be very well aware of what the change in scope rules are. A change in scope has to result in an increase of at least 5% in your existing rate. So you need to think through it carefully, seek accounting advice, and I suggest that you really do pursue that change in scope so your reimbursement will increase.
Absolutely.
Okay. Here's a list of some of the documentation you need. A narrative, you have to do a map, 100, 500, a letter and describe it, etc. So, okay. Now, for substance use disorder treatment, we gave you all those statistics about how prevalent this is. What we want to suggest to you is that you also consider implementing a substance use disorder treatment program. We're going to suggest to you, too, that you implement a medication-assisted therapy, which essentially is using Suboxone. Now, one of the reasons that this is so important, I think, for behavioral health patients and substance abuse patients is that there are some studies that have shown that patients with addiction issues who are actually admitted to programs where they go through a detox or an inpatient stay, et cetera, that when they are dismissed, that there is a incredibly small percentage of those patients who actually follow up with outpatient services. So there's a huge need to follow up with services for patients who have gone through a medical detox, who have been through a program that is an inpatient program, et cetera. The lack of availability of treatment options in our rural areas are so significant. So the other problem is that once patients have gone through a detox program, they are more susceptible to overdose if they have been they have abstained for a while. So for many reasons, having follow-up services are so very important for the patient.
Absolutely, absolutely. And, not for the sake of today, but the DEA limits the number of patients that you can see for Suboxone. And because of the limited number of physicians that offer the medicated assisted therapy, and the high statistics that we have for people that are addicted to opioids, it's just a huge need for our rural health clinics to fulfill some of that space that's needing to be taken care of.
Okay. Now, I think most people probably know that if you're going to engage in a medication-assisted therapy program, that you have to have training and a data waiver.
Mm-hmm.
Those waivers have been increased. A nurse practitioner is certainly eligible to essentially obtain a data waiver.
Yes.
And that there are increases in the number of patients that you can treat with after you have accomplished it for a year. And then there's some other programs that you can even raise your limits even higher. Now, we also want to point out to you that our Kentucky Board of Medical Licensure, as well as our Kentucky Board of Nursing, has very strict requirements for prescribing Suboxone. We've listed some up here. You have to document extensively your medical history. You have to do some testing, obtain CASPER reports. You're supposed to perform a physical exam. You have to give a diagnosis that the patient is actually in opioid withdrawal. And then you have to do education, and you have to obtain extensive consent. And then it goes on. So you need to be very aware of what those requirements are. Essentially, the Board of Nursing and the Kentucky Board of Medical Licensure's requirements are the same. So here's some more. Please understand, too, that with our CASPER reporting systems and et cetera, the regulators are looking as well to see if our physicians and nurse practitioners are prescribing in a manner that is consistent with their requirements.
Yes.
Okay. Of course, President Obama signed the Comprehensive Addiction and Recovery HERA into law. It has expanded substance abuse treatments and services. It also is the statute that allowed nurse practitioners and PAs in appropriate states to complete the training to be eligible for the waiver. And then, again, we've pointed out that nurse practitioners are regulated by the Kentucky Board of Nursing, and those standards have been implemented through regulation as well.
It's really an exciting area that has opened up to nurse practitioners for them to be able to do that. I was very happy that law passed.
Now, we want to talk to you about essentially another way, our second way. Go back to the slide. We want to talk to you about our second suggestion, that providers need to learn, train, and use best prescribing practices. Now, I bet that you may be thinking that I'm going to suggest to you that you not treat paying patients. That is not what I'm going to suggest to you. The impact of pain on the American healthcare system and economy cannot be underestimated. The Institute of Medicine concluded that 100 million Americans experience significant pain, that it is a $600 billion cost for productivity, for lost income, and et cetera. Pain is the top cause of disability in the United States. While there have been significant improvements, the American Academy of Pain Medicine estimates that there are probably 76 million people who have chronic pain which is not adequately controlled. Pain is a hard thing to treat, but it is something that is a chronic problem that rural health care providers are going to have to continue to treat. Every provider treats patients with chronic pain, and we also understand the concerns and et cetera about managing those patients over a long process.
And, Lisa, there's been a lot of studies released on that comprehensive care for patients with pain. The family medicine news that we get in every month and the pain medicine news talks about some of those issues and some of those reports that have been released. And with patients that have this chronic pain, when they have other conditions and they're treated in their totality, it's actually helping lower their pain. After use of opioids.
And here, pain medicine news. You want to tell them about that?
Sure, absolutely. In pain medicine news, just this past month, actually, they had an article talking about disability presents significant barriers to non-opioid treatment, and many lumbar fusion patients are still taking opioids a year later. So we have two different articles on here that's very, very important. One, we're talking about the disabilities and the totality of that treatment being able to help lessen the pain. For instance, if you're treating the obesity of a patient, it can help lower the pain if they have lower back pain. But as far as the lumbar fusion patients, they are still having to take pain medication despite the fact that they have had surgical intervention. Unfortunately, surgical intervention is not an end-all cure-all, and they still have things like osteoarthritis in different areas and still require that treatment.
Now, we're going to suggest to you that you implement policies and practices that embody the Kentucky Board of Medical Licensures requirements for prescribing controlled substances to chronic pain patients. They are very detailed, but they are essentially a model of what your policies and procedures need to be and what you need to do to essentially manage these patients. I guess the long and short of it is that whether you like it or not, our rural health care providers are going to have patients who have chronic pain problems.
Yes.
And there's just almost no way to get around treating a chronic pain patient. So if you're going to do it, what we need to do is to make sure that your policies and practices are consistent with regulatory requirements. And we're going to talk a little bit more later about some other things you can do. But here we go. Here's a slide that says that 43% of physicians do not ask about controlled prescription drug abuse when taking a patient's health history. 19% of physicians haven't received medical school training in identifying prescription drug diversion. 40% of physicians have received any training to identify it. And legitimate prescriptions do remain the number one source of diverted opioids. Mm-hmm. Now, I also understand that a provider is very hesitant to prescribe opioids, but in some cases they have to do so. It is the medically appropriate thing to do. I also understand that particularly our rural healthcare providers, where the incidence of opioid addiction is so high, are concerned that they will be duped by patients who come and report simply to access more drugs.
Yes.
So, Gina, you're just really good at this. Would you help us talk through some of
Oh, absolutely. We'll talk about some of the diversion tactics that you guys face every day, some things that patients do in order to access those opioid medications. First and foremost, with any type of chronic pain management, always look at your diagnostic testing results first. Require your patients to have that diagnostic testing so that you can make a determination. Many patients can be very convincing. Even elderly patients are known to divert medications, and they come in and say, my back hurts or my hip hurts, and, it's an elderly patient in front of you. How could they be diverting opioids? And we unfortunately have to put that personal feelings aside and look at this for what it is, and make sure we have those diagnostic tests. Make sure you refer those patients out for those and get those results in. Other things that you need to look for with diversion is that, the old story, the dog ate my homework. I lost my prescription. Someone stole my prescription. Someone took one of my pills and I didn't know about it. I need another one, or I'm going out of town for 2 weeks and I need you to refill my prescription early. They've become very creative in how they ask, and they use a lot of very legitimate issues that would require a refill that you simply cannot do when prescribing opioids or any controlled medications. Also, when you require urine drug screenings to determine if they're being compliant with their treatment, if they are not compliant with their treatment, do not continue to prescribe that medication. Now, there are some things that you have to do to cover yourself as a practitioner when terminating a patient, and that we could talk about that at a later time. But this is something is do not continue to write those prescriptions for them when they've had these repeated
or document the reasons that you do.
It's absolutely make sure that's in there. So those are just some examples of diversion. And if you do random pill counts, if you have a policy with your patient that if someone is receiving a prescription for controlled substances, and in order to help prevent that diversion, you're requiring random pill counts, actually look at the pills. There are fake ones out there that people use for those pill counts. So those are just some things.
So do prescribe for legitimate medical reasons. Do document your history and physical exam. Do screen for substance use disorder. Do use proper prescription writing techniques. Do use electronic prescriptions where possible. And then avoid prescribing at intervals inconsistent with legitimate medical treatment. Avoid prescribing large quantities. Avoid issuing large numbers of prescriptions. Avoid warning patients to fill, well, you should never tell a patient to fill prescriptions at a different drugstore. And then understand that there has to be a relationship between what you're treating and what you're prescribing. Here's some red flags you also must want to note about patients. If a patient gives you false information, uses multiple pharmacies, has seen multiple doctors in a short period of time without a good reason, comes into your office with old records, claims is allergic to all other medications. If a patient comes from out of town, that seems to be a big flag. Comes in with and tells you what drug they want, how much they want, and only want that drug. That is a really good red flag.
And, Lisa, one thing that I would recommend is to go ahead, if you have a patient that you feel that does need an opioid treatment, go ahead and run a cancer report to see if they are shopping. Doctor shopping.
Yeah, you should run a cancer report anytime before you prescribe it. Yeah, we haven't written out exactly what the policies and procedures are that you have, but if you have questions, give us a call. We certainly can give you lots of information about the right kinds of policies, the right kinds of procedures, and we can meet and go over with you and your staff about what you should have in place, both for Suboxone medically assisted treatment, as well as if you should have a controlled substances prescribing policy, without question. So now, the other thing we wanted to talk with you about today is compliance and how you can use compliance and to essentially help you with the integration of behavioral health and substance disorders and prescribing into your practice. So, gosh, compliance is gotten to be such an incredibly important area for healthcare providers, and essentially having a compliance program is mandated. It is required, and I think a lot of providers don't really understand that it is. For certain providers, it's a condition of participation in the Medicare and Medicaid programs. So I think having a compliance program is what I like to say, it is the best risk management tool that a provider can have, both from regulatory risk, but also from quality of care.
Yes, absolutely.
Kind of thing. So anyway, couple things. We all talk about fraud, waste, and abuse, and it is so important in terms of compliance that we know what fraud is, that we know what waste and abuse is, and then we look at that very carefully, that we train our employees and staff, and then we have ongoing training about what these areas are because they change so often. These are the traditional waste and fraud areas. Billing for unnecessary medical services, those are easy. Charging excessively for services, misusing codes or claims, unbundling, all those kinds of things constitute waste and abuse and probably false claims. Now,
and, Lisa was talking about the coding earlier, making sure that you have the correct coding for your behavioral health services, et cetera. This is a really good example. When they went over to the ICD-10 codes, anything to do with opioid use or opioid care now, instead of one generic code, has, hundreds of codes. And if you accidentally bill that wrong code, you could have an issue in this area. So that is just to reiterate what Ms. Hinkle was speaking about earlier.
Okay. Now, the False Claims Act is such a tool for enforcement. What particularly the federal government, as well as our key TAM plaintiffs, use the False Claims Act as an incredible enforcement tool. The penalties are significant, civil monetary penalties from $5,500 to $11,000 per claim, 3 times the amount of damages, and you can certainly also be excluded from participation in Medicare and Medicaid. Also, and this is on this particular slide, what does it prohibit? You cannot knowingly submit a false claim for payment to the federal government, but look at this. If you discover that you have been overpaid, then you have a duty and responsibility to return that overpayment within 60 days. Otherwise, knowingly keeping an overpayment is also considered a false claim. So I think that's really, really, really important. Overpayment liabilities.
I'm sorry, what would you do to make that determination if you had an overpayment? How would you make that determination?
Well, I think that is a really good question. And it can be an exceptionally complicated question. And when does that 60 days start running? Essentially, it depends upon what you've discovered. If it's a very simple thing and you know what it is, then your clock starts running from that point. But what we encounter in our law practice is that there are often very complicated issues about whether it actually is an overpayment or not. So essentially, by regulation, you are allowed to do and are supposed to do reasonable investigation. So you have an opportunity to do reasonable investigation and to determine if it really is an overpayment. Now, The time clock doesn't start running for the 60 days until you get the determination that actually is an overpayment. It doesn't start from the investigation stage. But CMS has issued regulations that essentially say that you ought to wrap it up in 6 months. So that determination of whether there's an overpayment can be so difficult. And a lot of times we help our clients through those kinds of issues. Now, moving on to a little bit more about the False Claims Act, there are mistakes, inefficiencies, bending the rules, and intentional deceptions. So there are different levels of them, but please understand that even mistakes, if you should have known about it, could be considered a false claim. In 2017, $3.7 billion in settlement and judgments from Civil Fraud and False Claims Act. $2.4 billion was recovered from cases involving healthcare providers. And truly, the False Claim Act has been more than paying for itself and is just really a very effective tool for our federal government. Let's switch over. So this False Claims Act, what's that got to do with the opioid crisis? Well, we like to say that the Department of Justice's latest opioid crime fighting tool is the False Claims Act. And in fact, the Department of Justice has been using the False Claims Act to essentially investigate and essentially prosecute providers both on a criminal basis as well as a civil basis for false claims and for prescribing issues. So it really has become a very important tool for enforcement to address this opioid crisis. So let me talk to you a little bit more about that. For example, pharma. This Galena Biopharma settlement, $7.55 million. Galena paid kickbacks to doctors to induce them to prescribe a fentanyl-based drug. These kickbacks included free meals, $5,000 to $6,000 payments for advisory board participation. If you're a physician and you're offered an advisory board participation spot, please seek legal counsel. It has been a situation that has really incurred a lot of liability for physicians, and they don't understand it. This situation also resulted in, of course, 20 years in federal prison for 2 physicians. Now, this other one, the NSAID Therapeutics, has been another situation that is not totally resolved, but the CEO of NSAID Therapeutics pled guilty, and there have been prosecutions of multiple physicians as well as the essentially the guru owner of the NSAID Therapeutics. So it's just and there have been some physicians around Ohio who have been actually indicted for prescribing the medication. It's supposed to have been a cancer drug, but misrepresentations were made, and this cancer drug was being prescribed as a chronic pain treatment. Yes. And it's a very, very serious thing, and it goes to show what some of the tactics of our pharma companies have used to essentially lure physicians into prescribing. And we can talk about the OxyContin a little bit later, but it's really personally, it's been disturbing to me. So anyway, here's some theories about false claims and what they use. That the manufacturers have made misrepresentations about how addictive the medication actually is, and that they base things on sales volume. We look at the distributors and wholesalers too, and look at if the sales volume is higher than what it should be or what is reasonable, then essentially that has been an indication that the distributor should have known that it wasn't being prescribed for medically appropriate purposes.
Yes.
False claims have been used against pharmacies, and then, of course, with physicians. And these are some of the theories that have been used to prosecute false claims cases. Okay. Right now, we have opioid investigative trends. We're looking from hydrocodone to oxycodone, false attestations to obtain tiered drugs, fake oxycodone pills, diversion of our medically assisted drugs, diversion of potentiator drugs, and affiliated lab problems. Man, and that is really an important issue these days. Here are a couple other DEA settlements. University of Michigan, $4.3 million because they didn't police their medications. Mm-hmm. And essentially they were stolen by employees, and they did not have an adequate security program in place, and paid a $4.3 million settlement. Likewise, this other system. So if, in fact, you have medications within your practice, if you're distributing medications, if you're an ambulatory surgery center, if you're using medications, controlled substances, and procedures, you have to comply with the FDA and requirements, and we can tell you what those are. But essentially, you are required to keep those secure. And if you don't do that, you could be subject to fines from the DEA.
And, Lisa, that's another very good reason to make sure that you have those compliance plans in place and your policies and procedures updated to reflect those securities. One other thing I would like to tell you about the enforcement theories and some of the tools that our federal government is using to monitor prescribing and use of controlled substances. Within the Part D, the Medicare prescriptions, essentially by using data analytics and looking at the incidence and the actual prescribing, according to a study released by the OIG last year, 500,000 Part D beneficiaries received opioids exceeding CDC safety levels in 2016. In fact, of course, that's really just now coming to light, but what is happening is that the feds are sending out letters to physicians who have been designated or that they have been prescribing medications at levels that the government believes are too high. They're sending letters to them, asking them to reevaluate their prescribing practices and et cetera. So you cannot underestimate how important it is to the federal government in terms of looking at the data analytic tools that they are using now to actually look at issues. Now, I want to tell you a couple of things. We're running out of time, but let me give you a couple of suggestions on ways and things that you can do to include in your compliance plans. First, you need to include in your compliance programs, not just our traditional, I know we've talked a lot about false claims, HIPAA, all those different areas of compliance, but you also need to incorporate a compliance strategy that looks at your prescribing. Incorporate those CDC prescription guidelines across your clinical practice. Set up a data compliance monitoring system. Look to see that your prescribing is consistent with standards as much as you can.
you need to have an audit that looks at a sample of records where controlled substances are prescribed to make sure that you've got the drug contracts, that everything is consistent with all those Kentucky Board of Medical Licensure and Board of Nursing requirements. Do that 3 times a year, 4 times a year. Look at a sample of those patient records. We also suggest that if possible, and maybe through your EHRs, you are able to monitor or keep a log of what your prescribing is, and such that you can determine if your practice is an outlier. Remember that the Kentucky Board of that we have statutes now that define what are pain treatment facilities. So you should be looking to make sure that you are not getting over that threshold of prescribing controlled substances to chronic pain patients at a rate that is higher than, I think it's 50%.
Yeah, it can't be over 50%. And then also the reverse Caspers.
Oh, the reverse Caspers are really important too. Look at your prescribing practices. So, and then also think about maybe if you have patients using a lock-in agreement as part of your controlled substances agreement with those patients. So that's 4 or 5 different things that you can do as far as including a compliance component for looking at your prescribing of opioids. And we think those are really important, and we just cannot emphasize how important compliance is. There's one other thing that I wanted to talk to you about that I think a lot of people may not know, but there was a new law that was passed that became effective. It's called Eliminating Kickbacks in the Recovery Act of 2018. We call it ECRA, E-K-R-A. And what it was intended to do is a very long, involved law, but essentially it was created to address what was called patient brokering, where recovery homes and treatment facilities would essentially hire third parties to go out and recruit patients in exchange for payments. But it also had significant applications for laboratories and others involved in providing behavioral health services. So what you need as you integrate your behavioral and substance disorder treatment into primary care, you need to be very sure that your policies and procedures and practices for ordering laboratory services in particular is in compliance with state and federal law. So that's a new area that you need to be aware of that has just essentially coming. We don't even have regulations on it yet, but it is something that is out there. So let's see. Anyway, well, I hope we've given you all some good things to think about. I know I talked about treating chronic pain patients and talked about how prevalent pain was, but I also told you that you can't have more than 50% of them in your practice unless you have a physician who is certified in pain. The reality of it is our rural healthcare providers are the ones on the front line. You are the ones who are dealing with the patients who suffer from substance use disorders. You are the ones who are dealing with patients who suffer behavioral health problems. You are the ones who are dealing with patients who suffer chronic pain. And you're important providers. So we are so thankful for you. We think you do great things, and we hope this program has been helpful to you. Now, if there are any questions, we'll be happy to take you. Okay. Thank you all so much.
This is advertising material.